Hello everyone, and welcome to this audio podcast as part of this part of the series, the SZ Loci Equinox. This is the Shientist, and this is an audio podcast that is an RPSG and KDOS collaborative along with a Storm Ballistix production. This is audio podcast as part of the Ballistix edition. And this is Shientist, and I'm going to provide an overview surrounding primary care in context, in and around nephrology or nephrology basis. So, in relating to establishing causes and preventing chronic kidney disease or CKD, literature and evidence highlights that historically or even retrospectively, CKD occurs in the elderly when through this particular series in this Storm Robotics production series in this audio podcast series, listeners would have hopefully heard that CKD has incidences and prevalences surrounding both both populations or various populations between, for example, pediatrics, the young people, middle-aged, and the elderly. So retrospectively, where literature or evidence indicates that the elderly are primarily affected, it is actually where various various incidences and prevalences according to particular conditions that surround CKD that affect various various age groups, and also where for example there is evidence to indicate, for example, that CKD does have incidences and prevalences across ethnic minority populations. However, depending on the form of CKD or chronic kidney disease, generally CKD can affect various ethnicities, and some of the common causes of CKD are depicted here. So, for example, nephropathy, hypertension and renal vascular disease, glomerulonephritis, interstitial nephritis due to reflux nephropathy, and polycystic kidney disease, and also obstructive uropathy. And to be aware, for listeners to be aware that the common causes of CKD listed here are not restrictive. There are various other forms of CKD, chronic kidney diseases, that affect different ethnicities, and also different age groups and at population health level as well. So just to be aware that these are some of the common causes of CKD, at least that have been documented as well. The CKD stages are evidenced as 1 through 5, and this a table highlights the different stages, where for example stage 1 to 2, stages 1 to 2 are generally are stages where in context of severity, in primary care, it's bases where where primary care primary care teams look to sort of monitor CKD stage this CKD stage sort of annually. Where there's stable state CKD stage 3, in primary care, the basis is to monitor annually as well. When there's evidence of progressive CKD stage 3, CKD stage 3, and for example, where there's a reduction in the estimated glomerular filtration rate of, for example, more than 2 mL per min over 6 months or more, then in primary care, the process is to monitor on a 6 monthly basis, and in and around CKD stage 4 and 5, in primary care, the basis is to monitor around around a a 3 monthly basis, on a 3 monthly basis, as appropriate. In and around cause and prevention. So establishing the cause around CKD usually requires radiological involvement, and may require renal biopsies in some cases, and it's generally important because in some cases treating primary disease prevents renal damage, and also control of arterial blood pressure and reduction of proteinuria in recipients, for example, who may have particular forms of chronic kidney disease or CKD. It's important for recipients to have an understanding with their health professionals in and around arterial blood pressure and proteinuria, where it can prevent deterioration, where these sort of factors can prevent deterioration around renal function, and if not renal function is in totality, then in health professionals are to provide a basis in and around, for example, renal insufficiency, and the factors that can prompt renal insufficiency. Proteinuria also predicts progression to end stage, predicts or leads into progression of end stage renal disease, or ESRD. And if proteinuria is decreased, if proteinuria is evidenced, and alongside proteinuria there is evidence of renal insufficiency, then recipients, suspect or high risk recipients should be followed up in between primary care and secondary care, in context of the pathway that is in regard to end stage renal disease, or end stage renal disease, or ESRD. Drugs that so in relating to establishing the cause of and again preventing CKD, there are certain medicines that can counteract the action of important physiological component in and around renal function, known as angiotensin 2. So medicines that counteract the action of angiotensin 2 to, for example, lower proteinuria and slow the rate of CKD, chronic kidney disease progression in both renal disease or renal failure that are aligned to proteinuria and hematuria, or where there's sort of susceptible causes to and for individuals who might be bleeding through voiding, for example. Then it's important for recipients to have a basis around from sort of their health professional teams in and around the medicines that can both be sort of advantageous and disadvantageous in and around that. And in about a quarter of recipients receiving different forms of renal replacement therapy, the cause of underlying renal disease is often not particularly known. However, renal registry data have allowed tracking and sort of documentation and evidencing of certain disease, renal based diseases a little better, owing to the epidemiological and statistical analysis that sort of take place in between areas of sort of population health and healthcare practices. Around CKD sort of complications, treatment of anemia, for example, with recombinant human erythropoietin, avoids the requirement for blood transfusion and improves the quality of life and sort of capacity for red cell production and function. And the use of erythropoietin is obviously nothing new in recipients who fall into CKD or ESRD. However, suffice to say, the management of renal anemia has often coexisted coordinated by specialist nurses with sort of expertise between primary and secondary care in the assessment and prescribing and monitoring of this particular sort of complication in recipients who have sort of compromised red cell function. And treatment of iron deficiency alongside sort of erythropoiesis tends to be sort of warranted or required to ensure there's efficiency around for example, oxygen saturation. So treatment of iron deficiency is required to maximize erythropoiesis and where there's evidence of severe forms of anemia in recipients, then intravenous iron can be used. Excuse me. The management of mineral bone disease in CKD can be another complication, and is generally complex and rapidly advancing as new treatments to control, for example, calcium phosphate parathyroid levels are generally being investigated and experimented in sort of documented literature and through sort of clinical practices, etc. Calcium phosphate and intact plasma parathyroid should be measured in sort of recipients with chronic kidney disease or CKD, and where there's glomerular filtration rate or estimated glomerular filtration rate less than 60 ml per min. In relating to a sort of renal replacement therapy preparation, so late referral can be defined as referral of a recipient with progressive renal failure from primary care to secondary care less than 3 months before the requirement of renal replacement therapy is formally required or needed. And about a third of recipients are referred to a nephrologist at a late stage of renal disease, and generally this has been associated with sort of poorer sense of well-being, if you like, in recipients at the start of this form of renal replacement therapy known as hemodialysis, and worse outcomes are evidenced as worse outcomes have been evidenced as a result, and can sort of implicate sort of the costs in sort of patient care from both the patient side, or the recipient side, sorry, and also from the healthcare side as well. And all recipients with a progressive increase in, for example, the biomarker serum creatinine, or where serum creatinine level is used, need referral, or would require referrals to a nephrologist and preparation for a form of renal replacement therapy. So in relating to the preparation around renal replacement therapy, or RRT, identifying and treating causes of renal failure are important, and wherein, for example, there are causes that are reversed, where there are causes that can be treated if between primary and secondary care sectors. For example, a cause can be sort of reversed if for example sort of the referral between primary and secondary care is done in through adequate timing, to preserve mainly to preserve sort of renal function where there is sort of where there is, for example, renal parenchymal or renal tissue that can still be preserved and can still be of use in and around renal function. Slowing the progressive decline in renal function is important generally, and slowing the progressive decline in renal function is important, and managing sort of the complications associated with chronic kidney disease are also important. The entry into renal replacement therapy sort of programs for all recipients who might benefit requires involvement from multidisciplinary teams between healthcare sectors, and CKD must be identified as sort of at an early stage so the appropriate treatment can be initiated and the need for nephrological referral is assessed appropriately. So the evidence has indicated that a large number of recipients again can go with CKD or symptomology around CKD can go undiagnosed. The majority of recipients with CKD are not do not sort of undergo routine or regular monitoring around renal function or related parameters to enable appropriate management of progression and complications of renal disease as a routine basis in at least sort of primary care in at least sort of primary care settings. Implementation of guidelines relating to the identification, management, and referral would require and does require sort of a considerable change in current practices and additional resources in sort of particular settings in and around primary care. In context of what to monitor in primary care, so recipients who are suspect or high risk mainly is arterial blood pressure or ABP, bloods, and the bloods can include, for example, hemoglobin, creatinine, and estimated glomerular filtration rate, sodium, potassium, calcium, phosphate, where phosphate is as a parameter generally the sort of basis around sort of phosphate is annually and if it's less than for example 70 nanograms per liter, no further investigations are generally required unless a recipient goes into stage 4, into CKD stage 4, and urinalysis in particular, urinalysis can be more important in particular forms of CKD, and aspects of polypharmacy, for example, and also including sort of any sort of over-the-counter medicines as well. I want to say thank you to colleagues who helped develop this overview, and this has been another Storm and Ballistix production, and as part of the audio podcast series, the SI Loci Equinox, and thank you for taking the time to tune in on this. Thank you.